Worldwide, there is more pressure on emergency physicians and other specialists to perform diagnostic ultrasound in their clinic. With better image resolution in portable ultrasound devices, there are some applications now available in the musculoskeletal arena. Ultrasound is reasonably economical, fast and safe compared to other diagnostic imaging tools, and with expert education can be used as well in the primary care setting. Ultrasound has a very important role in supplementing physical exams and blood tests. In the following lecture, Catherine Eller, senior sonographer at a private radiology clinic in Australia and lecturer and tutor for emergency medicine courses, will explain how ultrasound in the MSK area can be applied in a primary care setting. Here you will learn some of the applications possible in the areas of the shoulder and knee.
In this lecture, we are going to present the use of handheld ultrasound devices in the primary care setting with the focus on musculoskeletal applications. Here are some of the advantages of point-of-care ultrasound. We have the ability to do dynamic imaging, we have portability, we have an immediate result, and we also have a possibility in some cases that it may reduce the number of X-rays we perform and therefore reduce the radiation exposure. Swelling and pain in joints is a common presentation in the emergency department, which can be caused either by injury or types of arthritis. Joint effusions after injury might implicate a more severe injury to the surrounding ligaments, tendons, or an underlying fracture. Ultrasound, for example, can be used to detect joint effusion or hematoma from a fall, which may direct the doctor to have further tests performed, such as an X-ray to rule out a fracture. Musculoskeletal pain, the most common cause of disability globally, is most frequently seen and managed in primary care. People with musculoskeletal pain in different body regions share similar characteristics, prognosis, and may respond to similar treatments. The aim of this lecture is to introduce and demonstrate the use of handheld ultrasound devices in primary care setting to identify the cause of musculoskeletal pain and to decide on the next steps in care and treatment. These are the many causes of shoulder pain, and in this point of care lecture, we will focus on just a few. For example, bursitis, rheumatoid arthritis, which will include looking for fluid in the bursa and joints. We will begin with the shoulder. The three pathologies I will demonstrate how to scan for are biceps tendon fluid, subacromial bursal fluid, and shoulder joint fluid. So now we're going to look at the shoulder anatomy. Here we have the largest bursa in the body and one of the most affected, and that's the subacromial bursa, sometimes called the subdeltoid bursa, sitting here under the acromion process, lying between the acromion process and the deltoid muscle and the rotator cuff tendons. There's a normal amount of fluid in the bursal sac that helps to reduce the friction during movement of the shoulder. This normal amount of fluid in the bursa is not usually seen on ultrasound and will only become apparent in the case of bursitis when the bursa thickens and fills with fluid. So now we'll look at the musculoskeletal shoulder technical guidelines for a full shoulder ultrasound that we may perform in our practice. That includes all of the list of structures you can see here on this slide. When we perform our POCUS shoulder ultrasound for musculoskeletal applications for the shoulder, we're going to focus on these structures alone. Our bicipital groove, looking for fluid in longitudinal and transverse. Our subacromial bursa, also looking dynamically for impingement. Our posterior glenohumeral joint recess. And we can also have a look at the acromioclavicular joint. Okay, now we'll look at the general musculoskeletal appearances. Here we've chosen a slice through the shoulder at the level of the supraspinatus tendon. And you will find, of course, our transducer is sitting on the skin. So this is our skin layer. Underneath this, we have our subcutaneous fat. Between the fat and the muscle, there may be an echogenic fascial plane between them. Within the muscle, we might have some echogenic fascial planes as well. So underneath our deltoid muscle in this case, we'll have our bursa. This is represented as an echogenic line, unless of course there's pathology present where there'll then be black or anechoic fluid in that bursal plane. Underneath our tendon, we'll have our anechoic cartilage sign and then our bony echogenic cortex. Behind the bony echogenic cortex of the surface of the bone, we'll have posterior shadowing. Let's take a look where the biceps tendon lies on the model now. So coming over to the shoulder model we have here, we're going to look at the transducer positions for looking at the biceps tendon sheath, the subacromial bursa, and the posterior joint. To begin with, we'll place the transducer in a transverse plane over the proximal humeral head, looking for the bony outline of the bicipital groove. By sliding the transducer towards and away from the marker, we'll center the bicipital groove in the middle of the image. Then to see the tendon, we're going to slightly tilt caudally or cephalically to reduce the anisotropy and allow us to see that tendon well. Then we're going to scan caudally and cephalically along the biceps tendon to look for any fluid in the tendon sheath. We can then rotate the transducer into a longitudinal plane and scan from side to side. Back into our transverse plane, we're going to slide cephalically until we see the bony shadow from the acromion process of the scapula. Rotate the transducer so that the marker end of the transducer is approximately at 8 o'clock position, and scan up and down that region to assess for any subacromial bursitis fluid sitting over the top of the supraspinatus tendon. Now we'll have a look at the posterior part of the shoulder where we're going to look for any glenohumeral joint fluid. The muscles have been cut away down to the deltoid muscle itself. We're going to place the transducer in a transverse plane just below the spine of the scapula and then slide the transducer towards the humeral head in order to see the glenohumeral joint. Then sliding up and down that position to get the best view of that joint and assess for any fluid. On our live demonstration, we'll also internally and externally rotate the humerus to bring the fluid out to its maximum amount. And that concludes our demonstration on our anatomical model for the shoulder. So now that we've had a look at the model, we'll go on to look at the ultrasound correlated pictures. Here on the left, we'll have our longitudinal image of the biceps tendon, the long head of the biceps tendon, superiorly here with the bony cortex behind. And on the right-hand side, we have our transverse image where our biceps tendon is sitting in that bicipital groove. As you can see in these images, the biceps tendon sheath has some fluid in it on the right, and on the contralateral side on the patient, we have no fluid within that sheath. Fluid within the biceps tendon sheath is an indicator that there may be an injury within the rotator cuff, for example, a supraspinatus tear. Now we will have a look at how we actually perform the biceps tendon and biceps tendon sheath scanning. On the left here, you'll see the patient position. We have the arm bent at the elbow and placing the hand on their hip. Then place the transducer in a transverse plane at the top of the shoulder here anteriorly. With the marker end of the transducer medial, slide the transducer medial or lateral to look for the bicipital groove, which appears as a small rounded dip in the bony cortex of the humerus, as you can see here on the image. Adjust the depth and the gain to have the bony cortex at the posterior part of the image, and then tilt the transducer caudally or cephalically until you see the tendon within the biceps groove. Slide the transducer now caudally and cephalically to survey any fluid within the sheath area. Now rotate the transducer 90 degrees clockwise into a longitudinal plane and tilt or slide the transducer along the long axis to bring the biceps tendon into view, as we see here. One of the most common causes for shoulder pain is bursitis, as we can appreciate here in this image. We can see fluid here in the bursa. Ultrasound has sensitivity of around 80% and specificity of 94 to 98% to detect subacromial bursitis. Bursitis will often go hand in hand with an impingement diagnosis because as the arm is raised, the thickened bursa is unable to slide easily under the acromion process, causing further friction, pain and inflammation. These are the signs and symptoms we may find with subacromial bursitis. There may be a gradual onset of the pain. The pain may be anterior or lateral on the shoulder. The pain may actually radiate down the arm. The pain may increase when lying on that affected side and increases during the night at sleeping. There is often an increase in pain with abduction as well. The fluid can be anechoic or have internal echoes and septa, as shown in these two images here. So we've got the anechoic fluid here, and we've got the fluid filled with echoes that almost mimics the same ultrasound appearance as the tendon below. As you can see, the subacromial bursal fluid on the right equals around 2.7 millimetres and appears normal on the left. Now we will cross over to how to scan the shoulder to assess for subacromial bursitis. Have the patient seated facing toward you. Bend the patient's arm at the elbow, as we see here in this image. Push the palm and elbow directly back so that the palm of the hand is resting on the hip. For the right shoulder, place the non-marker end of the transducer over the acromion process here and rotate the non-marker end around to about the 8 o'clock position. This will obviously change depending on the patient and their anatomy underlying. Slide the transducer anterior to posterior, so from anterior to posterior, until you can see the bursa overlying the supraspinatus tendon. As we can see here on the image on the right, a bursa distended over 1 millimetre is considered a possible cause for the patient's pain. Before we begin with the hands-on scanning, a very important ultrasound phenomenon we need to discuss is anisotropy. This is very specific in musculoskeletal imaging of tendons, ligaments, nerves, and to a lesser degree, the muscles. Anisotropy occurs when the angle of incidence does not equal the angle of refraction. Anisotropy refers to differing ultrasound appearances of structures depending on what angle the ultrasound beam is incidentating the underlying structure. Scanning through the entire structure at various angles is often necessary to ensure that the appearance is indeed an artefact and not a sign of true pathology. So when is it anisotropy and when is it real? As with all ultrasound applications, we must prove the abnormality in two planes at 90 degrees to each other, for example, longitudinal and transverse. We may also need to scan from a different ultrasound window or transducer position. So here in this slide, we can see on the left-hand side, we have the tendon looking anechoic. This is because the angle of inclination, directed here by the arrows, are not hitting the fibres of the tendon at 90 degrees. If we transition over to the right image here, we can now see the fibrillar pattern of the tendons. That's because now the angle of inclination is around 90 degrees to those structures. So we have had to move the transducer in order to get that image. On the image on the left, we have part of the biceps tendon appearing hypoechoic and almost anechoic in the longitudinal plane here. The anechoic appearance gives the impression that there is no tendon there visible. In order to see the true normal tendon echogenicity, we need to tilt the transducer along its long axis to bring the ultrasound beam 90 degrees to the tendon fibres, as we can see in this clip here. Once the beam is intersecting the tendon fibres at 90 degrees, we can see the normal tendon, as in the still image here on the right. Here on the left is the same patient as before with an incorrect angle of inclination of the biceps tendon in now a transverse plane, causing anisotropy, so that as you can see, the tendon disappears and is actually displayed as anechoic. By tilting the transducer slightly cephalidly, the tendon is now visible, as you can see here depicted in the image on the right. The ultrasound clip on the right is showing the posterior glenohumeral joint. The glenoid process and humeral head both appear as smooth echogenic structures with posterior shadowing. A joint effusion is often associated with a rotator cuff tear and can be anechoic or have internal echoes. It is difficult to distinguish between a joint effusion and synovial proliferation in an inflammatory process with ultrasound alone. This is abnormal though and needs further imaging, for example with MRI. Now we're going to look at the posterior joint and show you how to scan. Palpate the spine of the scapula and follow it laterally toward the humerus head, here. Place the probe parallel and just below the spine of the scapula, with the marker pointing toward the humerus head at the level of the glenoid fossa. Adjust your depth and your gain until both the glenoid and humeral head are at the posterior part of the image, as you see here. The humeral head appears as a smooth, round structure located just lateral to the glenoid fossa. To assess for joint fluid, the next step is to ask the patient to internally, then externally rotate the arm with the elbow bent at 90 degrees and the palm facing up. At full external rotation, the maximum amount of fluid will be visualised if it is present. Now that we've covered the theory, let's move on to our practical session. Now that we've covered the theory component in our lecture presentation, we'll move on to our live scanning demonstration. For this, we're going to use the handheld ultrasound device with dual probe capabilities. Here we have our phased array end of the transducer and our linear end of the transducer. For nearly all musculoskeletal applications, we'll use our linear transducer. I will show you step by step how to access views of the shoulder and looking for fluid in our point of care setting. Now we're going to move on to our live scanning demonstration, where I'll be able to show you what we talked about in the lecture and how we're going to look at the shoulder in the point of care setting. We'll begin with the biceps tendon sheath, looking for fluid there, which may indicate another injury underlying in another part of the shoulder. First, we're going to ask the patient to bend their elbow and place their palm on their leg. This is a good neutral start position to look for the biceps groove, where the biceps tendon and sheath will be lying. We're going to select our musculoskeletal setting or soft tissue setting so that our linear transducer is activated. Place some gel either on the patient or the transducer. Transverse plane. Marker towards my thumb. Identify the humeral head proximally on the screen here and look for the dip in the bony contour, which is the biceps groove or the bicipital groove. I have identified the bicipital groove by the bony contour dip in the humeral head. Within that, we're looking for the biceps tendon or fluid in the sheath around the tendon. At the moment, what I can see is an anechoic area within the groove. I don't know if it's fluid or a tendon that's been ruptured yet. So I'm going to tilt the transducer caudally and it's still black. I'm going to tilt it cranially, and there I see the biceps tendon as hyperechoic now. So that means the black that I was seeing was actually just anisotropy. Once I've identified the biceps tendon, I'm looking for any anechoic areas around it, which would indicate fluid in the tendon sheath. So I'm going to slide my transducer cephalically until I get to the top of the head of the biceps, long head of the biceps, and then slide caudally, looking for any fluid in that biceps tendon sheath. There is none to see on this patient, so it's a normal biceps tendon sheath. I can then rotate the transducer so that the marker is now pointing towards the patient's head and continue just scanning through that biceps tendon area and biceps groove area. We had a look at anisotropy of the biceps tendon in the transverse plane. Now I'll just reiterate it in the longitudinal plane. On this image here, I'm seeing the fibrillar pattern of the fibers of the tendon nicely because our beam is intersecting the fibers at 90 degrees. If I tilt the transducer this way, so a little bit caudally, the tendon is now looking anechoic. Again, it's not due to fluid, it's due to anisotropy. So we're going to reposition the beam, and there's the tendon again, and no fluid in the sheath. From the transverse plane of the biceps tendon sheath, we're going to slide cephalically again, looking for the acromion process of the scapula and the supraspinatus tendon. So I'm just rotating the marker end of the transducer to about the 8 o'clock position, with the non-marker end of the transducer on the acromion process. Here on my image, and I'm just going to slide down off the acromion process. Here on my image on the right, I have the bony contour with the shadow of the acromion process. Deep to that, I have my humeral head. Between that, I have my deltoid muscle, and then deeper to that, the supraspinatus tendon. Our bursa will be lying between these two structures. First of all, I'm going to adjust the depth, and then I'm going to adjust the gain slightly. The best position now to open the bursa up is to ask the patient to push their elbow backwards and place their hand on their hip. So I'll just demonstrate this. So straight back, hand on hip, elbow back. What this does is just open up the bursa as much as we can and allow us to see the potential for any fluid there in that bursal space. And as we can see on this patient, there is no fluid present. We can slide posteriorly and anteriorly just to check the structures, and it's all looking normal. Normal meaning that the bursa is so thin that it's not able to be seen as a potential space. It's just a thin white line, as you can see in the middle of the image here. What we can do here, if we do see a thickened bursa with signs and symptoms of impingement, we can do a dynamic assessment, having a look to see if the bursa bunches under the acromion process with the arm in abduction. Usually I'll show the patient what I want them to do first, and then let them do it on their own. So I'll just take the machine and ask the patient now to raise their arm, watching the tendon and the bursa slide nicely under the acromion process. And again, in this case, there was no thickened bursa, so I wouldn't expect to see any bunching. Okay. That concludes the anterior aspect and superior aspect of the shoulder. Now we'll reposition the patient for the posterior shoulder positioning. So again, we've repositioned the patient so their posterior shoulder is facing towards me, and we're going to assess the posterior glenohumeral joint for any fluid. To begin with, the arm is in a neutral position. We'll place some gel back on the transducer here. Feel for the spine of the scapula. Place the transducer just under the spine of the scapula, which we can see here on the image. Slide the transducer towards the humeral head, and between the scapula and the humeral head is the glenohumeral joint, which we see as a break between the two bony contours, and sometimes you can see the labrum as an echogenic triangle, as on this image here. Now I'm going to ask the patient to put their right hand over onto their left shoulder, which will just rotate the humeral head around. As with all our other dynamic scans in musculoskeletal imaging, we're trying to bring out the fluid to the maximum amount. This position here will allow that. From this position here, we can slide down a little bit caudally and then again cranially, looking for any fluid in that joint space. Now the patient will externally rotate their arm and watching the humeral head moving and if there's any fluid apparent. Here we can see a nice smooth rotation and no fluid present. That concludes the posterior shoulder joint region for the musculoskeletal examination of the shoulder. I also reinforced the anisotropy issue that we have during musculoskeletal imaging and how important it is to recognise when it is anisotropy and not real pathology, for example, fluid. So here we have a clinical case with a gentleman who was 81 years old presenting to me with a fall 3 weeks ago. His clinical presentation was decreased range of movement and continuing pain. His history is that he had a prosthetic shoulder replacement in 2011 and he was also on blood thinners. During the clinical evaluation, his maximum point of pain was on the proximal humerus. He had a lot of pain on abduction and also forward elevation. Probably the differential diagnoses would include hematoma, rotator cuff tear and/or bursitis. I started my examination in a transverse plane over the proximal humerus as this was the point of maximum tenderness. My landmark here at the deep part of the image was the echogenic bony cortex with posterior shadowing, as you see here. The medial end of the transducer is over the coracoid process here. And if we look for the normal layers between the skin and the bone, we can see there's an extra layer against the bone, which is abnormal. So again, here we have the skin at the top of the image, the subcutaneous fat, and then the muscle. So between the muscle and the bone is all hematoma. So it just goes back to how we need to look at the image in layers to be able to work out if a structure is normal or abnormal. And again, in this case, it's most likely a hematoma around the shoulder prosthesis due to his traumatic injury. So here are some further images demonstrating the hematoma in a longitudinal plane from the anterior approach, as you can see here, and the posterior approach, as you can see here. Once the patient had an X-ray to confirm that the prosthesis was still in position, he was referred back to his GP for ongoing care.